Good afternoon, everyone. Welcome to day 10 of the NCHB Annual Conference Virtual Edition. We're glad that you're back on a Friday of this 2-week marathon of conference, and we appreciate everyone who's been with us throughout the conference. Today's session is the COVID framework. Where does your organization fit? Before I introduce our speakers, just a couple of quick housekeeping things. If you're not familiar with them yet, you all have entered the room on mute, and you'll be on mute for the entire presentation. But we do want your questions. We want to hear from you. So please, as the questions come to you, go ahead and type them in the question box, and we'll make sure we have time at the end to get as many questions answered as we possibly can. So with that, today's session is about the COVID framework, and we have two panelists with us today. We're excited to have both of them here and their just vast knowledge and expertise. First, we have Anna Leva, and Anne is a visiting senior fellow with the housing team at CBPP. Prior to joining the center, she was the senior policy advisor at the Corporation for Supportive Housing. From 2007 to 2017, she was a career federal official at the U.S. Department of Housing and Urban Development, most recently overseeing HUD's multi-billion-dollar homelessness and HIV/AIDS housing portfolio as the Deputy Assistant Secretary for Special Needs. She also worked as Director of Programs at the Community Partnership in Washington, D.C., and as a Human Services Consultant in multiple communities nationwide. In 2015, Anna Leva was named one of the 50 most influential leaders in HUD's 50-year history and was honored with the True Color Fund's True Leader Award. She was also a finalist for the Samuel J. Heyman Service to America Medal for the Distinction of Management Excellence in 2011 and was part of an interagency team that won a Sammy for reducing veteran homelessness in 2012. Anne has really been just a leader and a true champion in this effort for many, many years. And then our second speaker is Jeff Quarles, and Jeff is currently serves as the director for the Grant Per Diem, or GPD, National Program Office based in Tampa, and he served as the GPD Programs Director since 2012. GPD provides grants to community organizations that provide transitional housing and supportive services to homeless veterans and case management services to formerly homeless veterans. As director, he's responsible for the overall management and administration of the GPD program nationally and ensures that GPD-funded community-based programs provide quality services that follow existing laws and regulations. The GPD program has over 700 grants, including over 12,000 transitional housing beds and 128 case management grants. So as you can see, we have two real experts and pioneers in this work, and we're so lucky to have them both today with us. So with that, I am going to hand things over to Anne.
Great. Thank you so much, Cindy. And thanks to Jeff for being with me today. We've worked together certainly during my tenure at HUD, and I'm really honored to have him with me today. So we're going to start out super big picture with an overview of a project that a number of national organizations have been working on. That's called the Framework for an Equitable COVID-19 Homelessness Response. And then Jeff is going to get a little bit more detailed about how veterans homelessness fits into this framework and how you all might want to think about this work as you move forward. So as you can see on this slide, the framework itself is actually the sort of product of a large number of organizations that have gotten together. And really what we thought about was these are unprecedented times. This situation that we find ourselves in with the public health and with the economic crisis, in addition to the issues that have been raised since the murder of George Floyd, and certainly well before that, but the uprisings since that time, this unprecedented situation that we're in really called for an unprecedented set of partnerships. And you can see at the bottom of the screen, these are our experts in this field, including my own organization, the Center on Budget and Policy Priorities, the National Alliance to End Homelessness, the National Innovation Service, National Healthcare for the Homeless Council, Low Income Housing Coalition, the Urban Institute, and then two former executive directors of the U.S. Interagency Council on Homelessness, Barb Poppy and Matthew Doherty, really got together to pull this framework together and then develop all of the supporting materials for the framework itself. And if you haven't seen it, it is up on our website, and I can probably put it in the chat, but the website is, we just changed it, so bear with me. It's housingequityframework.org, and I would encourage you to take a look at that, and we'll walk through what the framework actually is. So if you can go, before we go to the next slide, I just want to note that NCHV did provide comment on this framework. So we asked them to look at it specifically with an eye towards veterans, so that we could make sure that the resources that are available for veterans experiencing homelessness and housing instability were included in this framework. So thanks to Catherine and the team at NCHV for doing that. First slide, next slide, second slide. So we always ground our work in data, and you all know this data, so I'm going to not spend a ton of time here. I think the most important thing to look at on this chart, this is point in time estimates that go back all the way to 2007. The blue line is all people experiencing homelessness at a point in time at the end of January of each year. The gray line is sheltered people, but really where I want your attention to be right now is on the green line, which, as you can see, since 2016 has been ticking in an upward direction. And this is something that I think was particularly compelling and important for us who are working on this framework to take into account, because we do have a lot of people living in unsheltered locations right now, and that number is increasing. So we want to make sure that the framework itself is addressing these issues. Next slide. We also want to make sure that we understand the sort of makeup of the households who are experiencing homelessness at a point in time. And I just also want to note this: the point in time data is not the only data that we look at. Certainly not when I was at HUD, and now that I'm out in the field working for a nonprofit, we always look at the longitudinal data as well. So I would encourage folks to be looking at that at the same time you're looking at the point in time data. But here you can see the really the breakout between the number of people and families who are experiencing homelessness and individuals, and for each of those household types, who is sheltered and who is unsheltered. So we're talking about a lot of unsheltered individuals and a lot of families who are in sheltered locations. Next slide. And then just sort of honing in, you want to go back one, I think, thanks. Honing in on veterans in particular, this is our 2019 data where we saw just over 37,000 veterans experiencing homelessness on a single night in January. 61% of those veterans were staying in some sort of sheltered location, emergency shelter or transitional housing. And on this chart, you can see the deeper blue means sort of the higher rate of veterans experiencing homelessness per 10,000 veterans. So we have a very large population, especially looking at the West Coast and in Colorado and in Hawaii as well. But a lot of veterans in different states. Nobody certainly is at zero yet. Next slide. Then the last data point that we really looked at as we were thinking about this, this work is the aging nature of our population. Overall, this is a really interesting paper for folks to take a look at if you haven't seen it. I know Dennis Culhane does a lot of work on veterans specifically. This is about age distribution more broadly across the homelessness the population of people experiencing homelessness. But what you can see here is how much older now the average age is for this chart is adult males now than 10 years ago or 20 years ago. So we have a cohort of folks who are aging, and in an age of pandemic and COVID-19, this is another issue that we really wanted to make sure that we were addressing as we developed the framework itself. Next slide. So at the very beginning of the pandemic, again, Dr. Culhane and some of his partners did an analysis of what they thought the impact would be on people experiencing homelessness and maybe what the related cost would be. I will tell you that because I'm a little bit of a nerd in these kinds of situations, I actually did the same analysis. It's not as academic as what Dennis and his team did, but I roughly came up with the same sort of total cost if we were to annualize it. And you can see here from this data, really what we were looking at was sort of costs related to two things in the homeless system overall: housing people who are in unhoused situations or unsheltered situations, and getting our emergency shelter system to a place where it was in alignment with CDC guidance. So that's around reducing density. I know that Jeff will talk about this a little bit, but that effort to sort of reduce density and stand up new either congregate or non-congregate facilities that follow CDC guidance is something that we did, not just for the population overall, but specifically for veterans experiencing homelessness. And then, really the total estimated cost for these kinds of activities over the course of a year was at about 11.5 billion. But what that didn't take into account was the need to actually get folks from those non-congregate shelters or congregate shelters into permanent housing and rehousing those folks as quickly as possible. So in further estimates that were done both by myself and by the National Alliance to End Homelessness, the total cost was about $15.5 billion. And in the CARES Act, specifically for homelessness, we got in the ESG program about $4 billion. So we do still have a need left, and hopefully Congress will move forward with a new coronavirus package that includes some additional resources, both for homelessness prevention and to ensure that we can continue these important activities related to the safety and health of people who are experiencing homelessness. Next slide. And then we also took a look at how both the economic and the public health crisis were impacting communities of color, and we know that they have been disproportionately impacted by both the virus itself and the economic crisis. So Black, Latino, Indigenous households are hard hit, and we needed to make sure that whatever response we have takes those disparities into account, because we also know that in homelessness writ large, Black people account for 40% of people who are experiencing homelessness, although they only make up about 13% of the population in the US. And Latinx people make up about 22% of the homeless population, but only 18% of the general population. So you can see that these racial disparities are playing out sort of in both arenas, or maybe all three arenas. And we need to make sure that whatever our response is takes those disparities into account. Next slide. So in order to guide the work and the framework itself and the work that we are doing as a sort of group of national experts, we came up with a number of principles that were important to us and that would help us make decisions and decide and figure out how to make recommendations around the use of resources. So first, we want to make sure that we're advancing racial justice and equity. So you're going to hear me use that terminology, racial justice and equity, a number of times. And we want to make sure that we are not exacerbating the disparities that already exist for marginalized populations as we address the COVID-19 response. We also want to make sure that we're addressing the needs of people who have higher needs first. So people who are unsheltered, people who are older, disabled, medically fragile, living in unsheltered locations. Really, we wanted to make sure that resources are put in place for them first, and that they're not left out of the response to COVID-19. We also have found that, especially when we are talking about an emerging and changing sort of landscape that we're in right now, like the one that we're in right now, it's really important to have partnerships in place. And that might mean partnerships between, organizations that serve veterans in a bunch of different ways, not just veterans who are experiencing homelessness, making sure that the needs of veterans and others are addressed within the emergency management context. I know that especially at the beginning of the pandemic, there were a lot of resources being run through local emergency management agencies, and that process really needed to include veterans, veterans experiencing homelessness and housing instability, and our other partners who are at the table. The other thing that I would suggest here is that we also need to work with organizations that maybe are not traditional partners in the homelessness work that we do, like smaller organizations that are more community-based, but that have a much deeper reach into highly impacted neighborhoods and communities. So, I would encourage folks, and we based the framework work on this, to both look up to see what kinds of partners you need to have sort of at the highest levels, but also to look into communities to see what kinds of partners could really make sure that we're reaching who we need to reach, especially around homelessness prevention. And then the last two are things that probably anybody who's on this webinar today listening shares along with us, which is we need to get people into housing as quickly as we can, and that housing is in fact a health intervention. And we need to act as quickly as possible. We can't continue to do business as usual. We need to make sure that we're working as fast as we can to get folks into housing and stabilized in the housing that they have. Next slide. And then the last thing I'll note around sort of our process was that we also felt like it was important to make sure that we were asking impacted people what they wanted from us. And we did that by conducting, and actually it says on this slide it was 10 focus groups, but it was actually 11 focus groups with a number of folks. And veterans were included throughout these focus groups. We didn't have one specifically on veterans, but veterans were included in all the focus groups that we conducted, or at least they were invited to participate in the focus groups throughout. And then I guess I would say in my own work in community, I've done both veteran-specific listening sessions and focus groups, ensuring that veterans have the ability to impact the design of our response. Because and also including veterans in broader listening sessions as part of a broader discussion. And in my experience, veterans experiencing homelessness and housing instability have a ton to offer and contribute in terms of how resources should be addressed, how or allocated, what their needs are, what they think program design should look like. So I wanted to just make sure that I noted that here, because it's a really important part of the step. It's an important step in the process, and it was incredibly helpful in every sort of context that I've done it. But here, listening to impacted communities was incredibly helpful. And really what we heard from them were 4 major themes. And remember that we did this in June of 2020 as the protests around the country were really heating up. So that also contributed to some of the discussion here. But the first one is that we need to reimagine emergency shelter options. Congregate style shelter was not working either in the pandemic, as we all know, but it also wasn't necessarily working for folks before the pandemic. And they asked for us to think about emergency shelter options in a different way. Want to make sure that our services are dignity-based. I've heard this in every community that I've gone to and done listening sessions, so I wasn't surprised to see it here. It's incredibly important to make sure that we're sort of person-centered and dignity-based, and this is something that I've also heard from veterans a number of times. Next slide. We also heard from them that affordable housing resources really need to be targeted to those who are most impacted by inequities, and that they actually didn't want to see police in the homelessness response system, and in outreach teams and that sort of in that sort of intervention. We also heard a lot about criminalization practices and how that is impacting people who are in unsheltered locations, and really thinking about how we can end criminalization of homelessness across the country. Next slide. So this is the framework itself. This is the original version of the framework. It really is sequenced in 4 phases, and each phase has 5 buckets of activities. We're in the process of revising this because we actually know that now we know more than we did when we originally created this framework. We know that folks are having to go back as the COVID numbers go up in a specific community. They're having to go back to their original public health response and make sure that they're beefing that up when the numbers go up. So what I would say here is really focus on the 5 buckets, which is of activities, which is activities around people who are in unsheltered locations, activities around shelters and how shelters operate, how housing works within this context, conducting diversion and prevention activities. And then this other bucket of key activities really is about long-term actions and how we should be thinking in the back of our mind, even though we're planning for items that we need to do right now. Some of these are really opportunities to learn and make changes in the long run that will be beneficial to the system and make our system stronger. So that's the 5th bucket. Next slide. These are a number of the materials, if you go to the website that I mentioned earlier, that we have out. We've been trying to do a video for every product that we put out. So there are a number of products. I'm not going to go into them right now, but I do want to make sure that you all are aware of the equitable, what's listed on here as the equitable geo-targeting tool. That actually is a great resource, and I will also put it in the chat when I can, a great resource that was developed by the Urban Institute as part of this partnership that really helps communities based on a number of criteria, helps communities focus down to the census tract level to see who's at risk of becoming homeless, and so that homelessness prevention and eviction prevention resources can be targeted at the neighborhood level. So that's a really exciting, and it's the newest product that we have out there. We're about to release as well our briefs on serving historically marginalized communities. That should be out hopefully next week. Next slide. I'm not going to spend a ton of time right here, but also just making sure that the framework is really grounded in equity-based decision-making and makes the case for ensuring that equity is part of your overall plan to address the needs of people experiencing homelessness, and in this case, veterans, to make sure that we're using an equitable approach. And we do make the case and provide a number of tools that you'll see on the next slide. So all of our tools have sort of a racial justice and equity component to them, and includes things like why we should be prioritizing highly impacted communities in the same way that when we were then as early on in HUD-VASH, we took the approach of ensuring that people who are veterans who are unsheltered got priority, and chronically homeless veterans got priority in HUD-VASH, for example. So we want to make sure that folks are looking at that and who is most impacted and prioritizing resources there. We have a number of guides, an equity-based decision-making guide. Again, this data and mapping technology that I just talked about, that will help really hone in on communities that are highly impacted by both the public health and economic impact of COVID-19. Next slide. And so I just want to spend a moment here on long-term change close up, because I think this is where folks are starting to put some energy and really think about how what we're doing now should inform how we move forward in the future. So this is just that box, the longer term actions in the 5 buckets. How are we going to do shelter in the future? How are we going to ensure that housing is addressing the needs of marginalized or highly impacted groups? How are we going to scale diversion and homelessness prevention in ways that make sense to help stop the inflow of people coming into homelessness? And on the next slide, you'll see that we have some ideas around that. And I know Jeff is going to go into a little bit more detail here, so I'm just going to note here that we want to make sure that folks, again, are sort of institutionalizing this justice and equity set of approaches and practices, including partnerships with people with lived expertise, and in this case, veterans. As I noted earlier, veterans have a lot to bring to the table in terms of helping us understand what their needs are and developing solutions. And making sure that we're integrating the needs of veterans into all of our emergency management planning and practices. That's going to be incredibly important as we move forward. It's something that I think we've learned on the front end here, and that we're incorporating veterans organizations and partners into this process so that they're part of both the planning and execution of these types of plans going forward, so that the next time we have a crisis, the needs of veterans and partnerships will actually be built into our response. Next slide. So this is just my contact information. Folks can feel free to reach out to me if you have any questions or want to have one of us come out and do, well, I guess we're not going out anywhere, to do on Zoom a presentation about the framework or talk through any of the aspects. So with that, I think I'm turning it over to Jeff to dive a little deeper. Thanks for your time, everybody.
Thanks so much. And Jeff, I'm going to hand things over to you.
Fantastic. Can you hear me okay?
Yes, we can.
Okay. All right. And you want to tee up my slides there? Fantastic. Well, first of all, Ian, thanks so much for sharing information on the framework. When it first came out, I had an opportunity to sit down and read it, and it was so thoughtful and just made sense. You know, it was very straightforward, very easy to read, which I think is really important, right? We can come up with a lot of great material, but if people won't read it, it doesn't engage them. It's not easy to follow. It's not helpful. And I just found it super easy to follow. It made total sense to me. I'm looking forward to the revisions as well as some of the additional tools that you mentioned to check out. So that will be fantastic to see. So I'm glad to have an opportunity to come and talk with everyone today. Thanks to NCHV for inviting me to participate. I get a chance to participate most years, and I wasn't sure what was going to happen this year, so I'm excited that I had a chance to be able to participate again this year. I'd like it to kind of tie in a little bit of what Anne was saying, is thinking about operating in this environment as from a public health perspective. You know, how do we protect and improve the health of veterans and other persons we serve in our communities? And if we think about our housing interventions as the first part of that public health response and a health response, it's a really important aspect of what we do. Part of that is making sure that we provide safe environments that reduce the spread of communicable diseases and align with local health department practices in your community. And one of the things that we found, we had an opportunity this year to, as things were going on with the pandemic, to kind of call around to each of the 18 DISNs to try to understand what was going on, and then to share information regarding some of the adaptations we made in the program, and answer questions about flexibilities. And one of the things that, we learned really quickly was everything was so different in each community. And some of it made sense. Obviously, you have different resources in each community. How COVID was playing out in each community was really different, and all the different resources that were available were different. And so trying to tailor what was going on was obviously a challenge. But in every community, the health departments were, they were the lead group in trying to coordinate what was going on, and it's really important to make connections with them. And developing processes that continue to support the access to homeless services. We want people to be safe, obviously. That is foremost in our minds, COVID or not. And one of the things that we want to make sure that happens is that veterans still have access to homeless services. Anne was just mentioning that the number of folks that are still unsheltered, it's really high. Folks are out there, they're very vulnerable, and we need to make sure that we can ensure that they can access the services. And lastly, we want to coordinate with healthcare services, whether that be for VA, for eligible veterans. It's Department of Veterans Affairs. Obviously, we have the Veterans Health Administration, all our medical centers, our outpatient clinics that we have available to work with you. But we also have veterans who aren't eligible for VA healthcare, and they still need access to healthcare, whether it be primary care services or mental health services. So these things are really important. Next slide. As we look at the pandemic, I'd like to spend some time thinking about where we were, kind of where we are, and where we're going. Kind of the past, the present, and the future, because things have kind of changed over time. When I've had an opportunity to talk with grantees, and I would say, how's it going, or what are you doing? And they would say, well, when things first started, we were doing this, and then as things evolved, we started doing this, and now we're doing this, and now we're thinking about the following things going forward. And from a policy standpoint in our office, and trying to think about whether it be the grant per diem office or the homeless program office in general, that's been our experience as well. And I'm going to kind of review some of that a little bit, but with an eye on the future, because we really have to think about what we're going to do going forward. Next slide, please. Okay, in the past, before this all happened, VA, the homeless programs had limited guidance around, what we're going to do about communicable diseases. you had individual program offices that would respond to inquiries, and they were basically done in silos. So it wasn't like public health issues weren't coming up, because they were. You had flu outbreaks, you had just a variety of things that would happen. We did the questions about bed bugs. I mean, we just had all kinds of things that would arise associated with the public health things, but the issues were dealt with in a program office, or what are we doing in Tampa about this, and there wasn't really kind of this national kind of response or kind of thinking about it. The options that we had for social distancing and isolation were limited. Even if we had those, even when we're thinking about placing people in motels, even when that began to happen, the capacity to provide remote services were limited. Even when we're thinking about it in the department and we're making shifts in how we're providing healthcare, it's like everybody needed to go remote, because we were wanting to social distance. Between the VA and our grantees, people weren't prepared to do that. Even if the technology existed, people didn't necessarily have the tools. They might not have had, the laptops, or they might not have had the iPads, or they might not have had the cell phones. And so we were in a position that we could not necessarily face these challenges in the way that we need to do right now. It's hard to imagine, I've been working from home just about every day now since, I don't know, March. And it's hard to imagine if you had asked me back in March, would that be the case? But yet and still we had to make those kinds of changes. Next slide. Okay, I didn't want us to forget what we're facing. I mean, this was yesterday from the CDC. This is everywhere. It's impacting all of us. It has changed the way that we live. It has changed the way we work. It changes the way we shop. It changes the way we socialize. It changes the way we sanitize. It has changed our lives, and in particular, it has changed how we serve one of our most vulnerable populations, homeless people. It has made things really different. And as communities have had to mobilize and programs have had to change, we've had to do a lot of thinking about doing things differently and thinking out of the box. On a national level, with just thinking about VA right now, as the CARES Act came out, the Homeless Program Office, got money to address the pandemic, working with the homeless programs. SSVF got some money, we got some money, HCHV got some money, and we're all, kind of working with trying to make adjustments in the program and develop a variety of ways to respond to the virus and help our grantees respond to that, our contract agencies. But beyond the funding alone doesn't do it. There had to be a change in how we thought about serving people regarding the pandemic, figuring out different flexibilities to ensure that we can continue to serve homeless veterans in a safe way, from isolation options like using motels and hotels, basically thinning out spaces, how we could do social distancing. Some programs had to cut themselves in half the amount of size. Some had unused space that they were able to adapt, and we were certainly supportive of that. Working across VA to just look at how we communicate about situations. I mentioned before, prior to the pandemic, somebody would say a situation came up in Tampa, and we would respond and say, okay, here's some thoughts of what you need to do. You probably need to talk to your public health department, work with your VA, and kind of let us know how it's going, make sure veterans okay. Now, as we have received inquiries from the field that still may come to our office, we'd reformulate the question, make sure we understood what the question was, work on developing a response. We have what's called a COVID-19 response team, get that information to them for them to take a look at kind of our response. They quickly turn that around to see what it has to do with some of our other programs as well, because it might just not apply to GPD. It might apply to HCHV or SSVF, and then come up with some standardized responses that we can get out to everybody so we can think across programs and figure out what we're going to do. A good example of that would have been when we first worked on talking about our isolation options. When that information came out and we were getting questions about that, the information came out from the department. It's like, here are the isolation options with regard to GPD, SSVF, and ACHV. And we sat down and made sure that we kind of talked about that together. Now, it's not perfect, and we're still working on it, but we're getting there, and we advance it every day. And I see we're up to the new normal, so let's talk about that. So now we're kind of living in the new normal, and we have to think about how we do things differently every day. So when I go to the drugstore right now, it's like, you got your keys? Yep. You got your cell phone? Yep. Got your wallet? Yep. Do I have my mask? Do I have my sanitizer? Right? Because we want to make sure we're protecting other people. You can't even legally go into a store or any business in the state of Florida without wearing a mask, which is good public health practice, right? So we've had to change how we're doing things, and hopefully you're doing that as well. Keeping informed on the updated guidelines related from CDC, from your local health departments, and from VA. Thinking about facility designs and processes to support social distancing. I know you've had to do a lot of that. Hopefully you're continuing to do that. Educating veterans around hygiene practices, which is really important. And now that you're getting folks off the street, I was on a Facebook Live meeting with John Kuhn and Eileen Devine on Tuesday, and John was talking about the fact, getting folks off the street, and talking about hygiene practices. Folks didn't even have the ability to wash their hands before because they were out on the street, and now we have to kind of talk with them about that and ensure that they have the resources to be able to do that. Continuing use of personal protective equipment, cleaning supplies, sanitizers, these kind of things. Developing internal procedures and protocols to guide staff. People need to know what to do, when to do it, and how to do it, and recognizing that these procedures and protocols may need to be revisited, revised as you go along, as we learn more. I know that's happening for us. In VA, one of the big things we're working on right now is we're having the medical centers work on testing protocols for all the medical centers for folks who are going into GPD and HCHV, and that will be a work in progress. It's not going to be perfect. It's going to involve our community partners as well, but it's something VA is committed to doing. Next slide. We need to continue to think about creative flexibilities. How we've been using the CARES Act funding. And I know when we first, there were some things that were really obvious to us, right? Initially in GPD, because this was the CARES Act funding was totally tied to per diem, right? And how much people could be allowed to be paid. But some of the questions like, well, what could you use it for? And they said, well, just start asking. And folks said, well, we're sick of people in motels. Can we get them cell phones? Well, what are you going to use the cell phones for? Well, we're going to do some case management services with them, make sure people are okay. Okay, it sounds good to me. So, I mean, there have been a lot of stuff like that, and we've had to think about what those flexibilities are and how to use the funding. We've been thinking of not only about programmatic flexibilities within GPD with regard to our transitional housing. We've been having conversations with HUD-VASH, because one of the things that we know, we got to make sure that people get into housing and stay in housing. We have some excess capacity in our case management grants in GPD. There's some excess vouchers that they're sitting around. They need to get used, and we have some staffing shortages we have to fill, and maybe there's some lower acuity veterans that we can serve in the GPD case management. So we've already started a demonstration project, the pilot. We got one that's already going in Walla Walla. I was on the phone with them yesterday. I've been in contact with some other grant per diem programs. Some of you will be hearing about that in the near future as well as we continue to learn more. It's really important for us to do continuous communication because information is changing. I mean, early on, it felt like information was changing every day. And it was just so hard to keep up with. And we're constantly cranking out information to make sure that it gets out to you. And some of it, depends on some of the questions we get. A few weeks ago, someone said, what do we do regarding CPR? Like, oh, okay, good question. And we talked within our team, and one of our team was on top of the CDC guidelines and as far as doing CPR in homeless programs. And so we put that information out, we put it on a webinar, we put it on our website. So there's that constant need to communicate. And lastly, in this new normal, we can't take our eye off the mission, which is ultimately get people into permanent housing. And it's going to be a real key in this pandemic to get people into permanent housing, because we know their chances of being safer are much greater, right? They have their own place, and we can wrap around services with them. So we need to do everything we can to help get folks into that housing as quickly as possible. Let's talk about the future. Next slide. It's not totally clear what the future holds, but certainly there's some need to plan for it. We have to think about what we've learned to help shape what we plan going forward. We certainly can't go back to doing things the way we did. We need to really make some changes. We know that communicable diseases will still be there. We know that when we have a public health crisis, homeless persons will continue to be among the most vulnerable persons in our society. So we need to be prepared for that. We need to think about which flexibilities that we developed and which ones do we need to keep. And so I'm charging you to think about that within your own programs. We're certainly thinking about it in our office and in the homeless program office in VA as a whole. What types of things that we change that we just need to keep doing. Some of them are very easy fixes for us. They're just program decisions, and we just do them. Other things we have to look at, other types of changes that we'd have to propose around regulatory things. But there's also things that you guys have changed within your own programs about how you operate and how you manage these public health crises. And I think you should consider which of these things worked out really well, and maybe you should just do them all the time because they just protect you overall. And for us, we're thinking about the long-term transformation of what we're doing with transitional housing. Any of you who are grant per diem providers probably heard me talk about this on our operational call. We're actively writing a capital grant to reduce the amount of congregate settings, looking at putting out money to have you develop individual units, not create more beds, but reduce the amount of congregate housing that we're having. And we're trying to tie this to a CARES Act fund. So this is something that we're actively thinking about, and hopefully you guys are too. Do we think about expanding a transition in place? Because those are already individual units. If we do that, what type of changes do we need to make it more user-friendly for you guys? There are a number of changes like that, obviously, that we're thinking about, and hopefully you are too. And we're always interested in hearing about the types of things that have worked for you, so that we can pass on not only best practices, but thinking about what we need to do for the future. Last slide, please. So more than anything else, I don't want to forget to say thank you. We know that folks are working really hard out there, and that the challenges have been unprecedented that you've been facing. And we want you to know we appreciate all that you have done all that you will do, and that we hope that you are taking care of yourselves, because it's easy for us who are giving care to others to not pay attention to ourselves. So we hope that you're doing that, and that you and your families are safe, as well as your staffs. And again, thank you so much for presenting with me. It was so much fun. I really appreciate the information that you have to share. And Cindy, I think we should probably try to do some questions.
Great. Thank you, Jeff, and thank you, Anne, both of you. We do have some questions coming in. The first question is, are there any specific considerations being given to the end of the eviction moratoria as they're happening now or towards the end of the year, and what are those considerations?
So could you repeat the question again?
It's around any specific considerations or planning that may be happening for when the eviction moratoria end. Wow.
I haven't heard much about that. They were talking a little bit about it on one of the other calls yesterday. I know that that's outside my office area. I don't know, Anne, have you heard much around that?
Yeah, so I think it depends a little bit on whether Congress ends up passing another coronavirus relief package that includes emergency rental assistance. I know that what passed on the House side was about $100 billion. And and obviously there's ongoing negotiations around that. So for right now, I guess what I would encourage folks who are listening in today to do is to work closely with their continuums of care who have that $4 billion in ESG money that can be used for homelessness prevention. I know that communities all over the country are thinking about how to use those dollars. As I said, we really want to make sure that people with the highest needs are addressed first, but that those funds can be used for folks who are very close to homelessness and for homelessness prevention. And I know a lot of communities are setting aside some of their dollars to do that. So as the moratorium ends, if there is not another resource in place to help pay for arrears, I think that communities are going to start trying to figure out how to use the resources they have in the most effective and efficient ways possible, including homelessness prevention. And that includes for veterans as well, obviously.
Yeah, I guess the other thing I would add, SSVF has received a good amount of funding to around CARES Act funding, which obviously includes prevention funds as well. So certainly, I know John Kuhn has been doing tons and tons of work around making sure that those funds get out to communities and those resources are available to support veterans, whether that be preventions. They have the shallow subsidies, and again, obviously, they've been doing emergency housing assistance, placing people in motels. And then obviously the rapid rehousing work that's being done by SSVF.
Yeah, if you take a look at the framework document itself, it does actually include in some of those, especially the economic sort of recovery area, I think it's like phase 3 right now, it does have some specific resources for veterans that can be used for exactly the purposes that Jeff just mentioned, including SSVF.
Great, thank you both. That kind of leads nicely into the next question, which is for Anne. Jeff, I'm not going to ask you to answer this one, but what do you think the likelihood is that there might be additional relief coming through additional CARES funding? I think someone's sort of asking you to kind of predict do you think there is going to be more than that $4 billion? Do we think there's going to be more money coming?
Yeah, it's funny, it like changes every day. If you'd asked me this question 2 days ago, I was pretty, sad about the fact that I didn't think that coronavirus relief was going to get picked up again certainly before the election, especially with the death of Justice Ginsburg and the priorities shifting in Congress. But as of today, I believe Speaker Pelosi is working on another package on the House side. So maybe I do think, to the extent that, and I can say this, I'm not in the government anymore, so I'm just going to go ahead and say it, to the extent that you want to make sure that your members of Congress know that there's a need out there for these resources and that we don't actually have enough. I think that that's a smart thing to do. I know that members of Congress have always supported the programs for veterans and for homeless veterans in particular. So it might be helpful for folks to reach out and do some education for their members of Congress.
Great, thank you. I realized that I had advanced the slides to nothingness, so I apologize to folks for that. And see, Jeff, there was a reason I wasn't going to ask you that question. The next question is a little bit more, just more about, I guess, a fundamental question. And Anne, you had mentioned in your remarks about dignity-based care, and that actually has come up in a couple of the other sessions that we've had this week around racial equity. There was one on aging veterans. There was one on veterans with various genders, identities, and orientations. So can you explain a little bit more what you mean by dignity-based care?
Sure. So, certainly what we've heard, what we heard in our listening sessions with people who were highly impacted or in marginalized communities, and that is consistent with over the last 3.5 years since I left government. I've had the opportunity to do these kinds of sessions with people with lived experience and expertise. And this is something that has come up in every single community that I have worked in. So I wasn't surprised to see it here. And that really is sort of this idea of centering the person rather than centering the organization. So really meeting the needs of people as they present and providing services that they want and need, versus trying to sort of fit somebody into a mold, into a pre-existing mold that's not very malleable, if that makes sense. So when we're talking about like dignity-based and person-centered, that's really what we heard from folks, including from veterans, that they want to make sure that that they're treated like a person. I mean, at its core, that's really what that is: treated with dignity, treated with respect. They served our country. They put their lives on the line. And in some cases, being in a congregate shelter does not feel very dignified.
Thank you, Anne. Jeff, did you want to add to that? I see you nodding.
Yeah, well, I've been in the GPD office since 2006. And, from the day that I got there, I know we have talked a lot about, it's like individuals over programs, right? It's like, it's about a person's individual service plan or care plan or housing, whatever you call it. It's about the individual. We've got to move away from programs driving people. It's got to be people driving programs. And for a long time, my background is in rehabilitation counseling, and in working with persons with disabilities. The importance of a person-centered plan is just vital. I mean, that's it. That's the way you do things, and that's the way you approach care. And I just think we can't not do that. And I think it ends up playing out in even how facilities are designed or how they're set up.
That's
And
right.
I can remember years ago, I used to be a car surveyor. I'll tell a very short story. I used to be a car surveyor years ago, and I went to visit this organization that served persons with disabilities. And one of the things you do as a surveyor is you talk to the persons who use the services and the families that use the services. And I asked the persons served, because they had like this committee, like, what do you guys, do these people listen to you? And if so, what are you most proud of for, what you've accomplished? And they were telling me about how they helped design the building. And when the building was designed, that the organization put the doors on wrong and made it more difficult for them to get in. And they saw this right away as they were getting this big tour of the building, and they had this big meeting with them, and they redesigned how the doors were done. And then somebody figured out, well, we probably should listen to them a little bit more, and looked at a lot of different ways that this facility was designed just based on listening to the people who are going to use it every day. And I think in many ways, this is what we should do when we're talking about, dignity-centered services. We really have to pay attention to this.
Thank you so much. We do have one more question, and I have to admit that I want to kind of end things on that note from both of you, because I feel like that so I may come back to that, but I don't want to disregard this other question, because I do think that that's a great way to sort of end and regain the focus, is that the focus of whether it's all of these systems and all of the processes and everything, we have to adapt and change. We have to keep in mind that these are individuals, and we have to serve them and make sure that what we're doing is working for them. The last question is probably more for Jeff, and it's really about if VA has thought about using any of their healthcare for homeless veteran funding to provide kind of wraparound health services for folks who are temporarily in hotels, motels, those kinds of things.
So the ACHV is a contract, so I don't want to drift too far from my knowledge base, but ACHV did get some additional CARES Act funds, and they did, part of that could be used for isolation options like motels. So what I would suggest is, if you have ACHV funds, is to probably talk with your local ACHV person, and then if they have questions about that, loop back to Eileen Devine and the ACHV team in central office. But they did get some funds, specifically CARES Act related, and actually when we developed the isolation options, they were part of that consideration as well.
Great, thank you, Jeff. I'm going to give you guys each one more minute just to sort of say last thoughts. It may go back to the dignity-based care, but just any last thoughts that you want to leave folks with. 6 months into a pandemic and everything else that's going on, any last thoughts for folks?
So, I will echo how Jeff ended his presentation, which is just to say thanks to all the folks who are out there on the front lines doing this work in sometimes volatile, and sometimes I've done a lot of crisis work, but it's usually a natural disaster, and this is just feels different, and I know how hard it is, and I just want to thank everybody who's on this presentation today for everything they're doing. I know it's sometimes volatile. I know it's been changing fast, and offer up, again, I put my email up on my slides, to please feel free to reach out if there's anything that you think is missing or that you need support on, that you think that group of folks can help with.
Yeah, again, I can't say thank you enough. I mean, people have been stepping up to the plate and just it's just been incredible. I got to we had I, I know I've been talking about the transitional housing, but you also have these service centers that we were kind of drop-in places. We got like 18 of them, and I had a call. It wasn't me. One of our staff had a call, and I got invited to listen to these folks kind of talk about the things that they were doing to continue to try to outreach to veterans in very unique ways and make sure that they were safe and the veterans were safe and people were getting connected to care because they were kind of on the front door of many services. And it was just so amazing to see the resourcefulness and the dedication. And I can't I can't speak enough about that. We still have a lot ahead of us. Um, but what I've always believed, if we keep the person that we're working with at the center of what we're doing, we're going to be okay. You know, if we're working with veterans and if the veterans are at the center of what we're doing, we're going to be okay. I know at times it gets, kind of bumpy. You know, we're working, VA is this big organization. We got these community-based organizations and, our cultures might be a little bit different and everything else. But the bottom line is if we keep the person we're serving at the center, we'll be fine because it'll keep our priorities straight. It'll help us think about what we need to do, and ultimately it'll help us achieve the mission that we have in front of us. So thank you everybody. Cindy and NCHV team, thank you so much for having us and being so supportive and still doing this conference in the middle of a pandemic. This is pretty remarkable. Thank you for that as well.
Well, thank you, Jeff, and thank you, Anne, and thank you all for joining us today and throughout the conference. We appreciate all of you and all the work that you do every day, and we hope you have a great weekend. Thank you very much.
Bye.
Bye.